Hello, ladies and gentlemen. Warm greetings from Bondent Group. We bring you yet another webinar which provides an experiential solution for your dental practice. Hope you all are doing good and keeping safe. I am Dr. Khanna, Clinical Innovation Manager. Bondent Group provides end-to-end dental practice solutions ranging from endodontic and orthodontic consumables to dental equipment like dental chairs, CBCT, loop, and microscope. For more information, please visit www.bondent.com. It is my pleasure and privilege to welcome each and every one of you. Thank you for taking out your time and attending this webinar. We have with us Dr. Fernando Duran today from the beautiful country of Spain. Hello, Dr. Fernando.
Hello, good afternoon, everybody. I hope you to enjoy our lecture about shaping the root canals.
Thank you, Doctor. Sharing with you in brief about our speaker, Dr. Fernando has a master's and PhD in dentistry from the International University of Barcelona, Spain. He is serving as a professor and head of department in the Department of Endodontics and Restorative Dentistry, Barcelona, Spain. He has published more than 50 articles in scientific peer-reviewed journals on different endodontic topics and contributed with chapters in textbooks. He is also an active member of the Spanish Association of Endodontics. Dr. Duran gives lectures and courses worldwide and has a private practice limited to endodontics in Barcelona. Thank you, Dr. Fernando, for joining us today. It is an absolute pleasure to have you for this webinar.
Thank you.
At the end of the webinar, we will be having a question and answer session. We request all participants to share your questions in Ask a Question bar in login page. Now, I would like to hand it over to Dr. Fernando for the webinar. Welcome once again.
Thank you very much. Hello, good afternoon. My name is Fernando Duran. I'm an endodontist in Barcelona, and I'm the head of the department in Universidad Internacional de Catalunya. Today, we are going to talk about instrumentation of the root canals. I hope you to enjoy a lot the lecture. Excuse me, I cannot change the slide.
So can you just click on the slide and then change?
Okay, thank you. Can you see the new slide?
Yes, yes.
Yes,
Okay.
Doctor, we can see the slide.
Okay. During the last 20 years, most of us, we have used 90 instruments to shape the root canals. We have obtained very good results in most of the cases. For example, here, we can see a case that I did some years ago with a severe curvature in the distal root and a progressive curvature in the mesial. With these 90 instruments, we can perform very well the instrumentation. But it's very important to keep in mind that even using the best systems in the world, we are not going to touch all the walls of the root canal. Here we can see a study that we perform, and any system touch all the walls of the root canal during instrumentation. So for this reason, it's very important the irrigation. With the files, we are going to shape the root canal in order the irrigant to reach the different parts of the root canal system. I usually use this needle. Why? Because this needle has two lateral exits, and these avoid the extrusion of sodium hypochlorite to the periapical tissues. And this is very important. So after the shaping, we irrigate between 20 and 30 minutes more in order to try to clean the lateral canals, the dentinal tubules, those parts that our files cannot reach. For example, in this case that we did in a lower premolar, we can see a bifurcation, we can see some lateral canals that were filled thanks to the irrigation. Why is not working this lower molar? This lower molar, the treatment, the root canal treatment, it's not working because there are bacteria inside of the root canal. So we cannot forget that the main cause of failure of the root canal treatment is the presence of bacteria inside of the root canal. So our main objective when we do a root canal treatment is decrease the number of bacteria inside of the root canal. If we decrease the bacterial load, we will have a very high success rate. For example, in this case, the first dentist that did the root canal treatment didn't disinfect correctly. After doing the retreatment, we disinfect correctly, and then we can expect success in most of our cases. What is the success rate that we can expect? We can expect around 85%, depending if the case has a previous periapical lesion or not. In those cases with previous periapical lesion, we can expect around 80-85% of success rate. On the other hand, in cases without periapical lesion, we can expect a success rate between 90 and 95. What is the objective of the cleaning and shaping? When we perform the cleaning and shaping, we have mechanical objectives and biological objectives. The mechanical objectives are carried out using the files. And what are the mechanical objectives? The mechanical objectives are to get a taper preparation. It means the peak diameter in the coronal part of the root canal and the narrower preparation in the apical part of the root canal, and no apical transportation. If we get this mechanical objective, we know that the obturation of the root canal will be easy, okay? So these mechanical objectives are important in order to fill the root canal correctly and in order to improve the irrigation. So, and what are the biological objectives of our treatment? First, decrease the number or remove the bacteria inside of the root canal in those cases that there is a necrosis in the root canal, and to eliminate the debris that we are going to create during instrumentation and remove the barbed organic tissue that is inside of the root canal. So, from now, we are going to focus in root canal conformation, the mechanical objective, and we are going to pay attention to the CC5 premium system. That is the system that now we are using. At the beginning, we started using stainless steel hand files. After a few years, we started using the rotary files made of conventional 90. And now we are using rotary files made of 90, made under thermal treatment. And as we will see later, this is very important because if we change the procedure of what the files are made, the properties of these files are going to change. Using 90 rotary files or reciprocating files to shape the root canal has a lot of advantages. Okay, it's easier to shape the root canal. We are going to obtain better results. It's much more difficult, the transportation of the apical part of the root canal. It's much difficult to make perforations, but there are some disadvantages. One of them is we can break the instrument inside of the root canal. So in order to try to decrease the number of fractures, we are going to review the basics of these 90 alloys. The fracture can happen due to torsional stress or cyclic fatigue stress. And in some cases, the fracture will be for a combination of torsional and cyclic fatigue stress. Now, first, we are going to start talking about the torsional stress. Why? Because if we know perfectly how to decrease the torsional or the cyclic fatigue stress, we are going to decrease the number of fractures in our clinical practice. So, what is fracture due to stress? Fracture due to torsion occurs when the tip or another part of the instrument binds within the canal, while the handpiece keeps turning, resulting in the elastic limit of the 90 endodontic instrument being exceeded. Summarizing from a clinical point of view, it means that if we press a lot, the file, we are going to break the file. So the fracture due to a torsion, it's because we press a lot the instrument inside of the root canal. So we have to try to decrease the force that we use during the instrumentation. So there is a book that, from my view, it's very helpful. It's useful for the dentists. It's the Mastering Endodontic Instrumentation, written by Mike Spaden. Why? Because in this book, Mike Spaden explains in an easy way why the fractures occur. And if you read this book, I have read this book many times, I can tell you that you are going to decrease the number of fractures during your instrumentation. So, now we are going to talk a little bit about the characteristics of the system, the CC Premium. This system is composed by 4 files. The first of them is the 17, has a 17 in the tip with a taper of 12. Is the file that we can see in the left. This file is used to open the root canal. It's designed to shape only the coronal part of the root canal and to eliminate the coronal interferences. Okay? The second one is that it's a file that its size is 20 at the tip with a taper of 4. And this file is designed to work the apical part and the middle part of the root canal. If we want to increase the apical diameter or we want to increase the taper of the preparation, we are going to use the 2506 up to the working length. So this file is designed to increase the size and the taper of the preparation. And the last file of the system is 35 taper 04. This file is designed to shape only the apical part of our preparation. In order to decrease the fractures due to torsional stress, we have to analyze or we have to review these 4 factors: the diameter, the efficiency of the file, if we use or not a handpiece with torque control, and if we do or not glide path. The resistance to the torsional fracture increase with the diameter of the file. What does it mean? It means that the bigger files are more resistant to torsional stress. So one of the procedures that we can do to decrease the torsional stress, so to decrease the number of fractures due to torsional stress, is performing a glide path. And what is glide path? Glide path is to obtain an easy, predictable, smooth path from the orifice to the apical terminus with a 15 hand file. If we can use a 15 hand file easily to the terminus and in a predictable manner, it means that we have glide path. So, to get the glide path, we can use hand files, 10 and 15, or we can use rotary path files. We are going to explain how to get the glide path using both, and we will explain the advantages of using the M-free safe path files. So, the first step independently, if we are going to get the glide path using hand files, manual glide path or rotary glide path, it's the negotiation, the scouting of the root canal. To this end, we are going to use a small K file, 8 or 10, and we are going to start with watch winding movements. We start with the watch winding movements, and when we reach the apical terminus of the root canal, we are going to start with the push-pull motions. When we feel that the file is super loose in the root canal, when we feel that the 10K file is super loose in the root canal, so we can do the glide path using hand files or rotary path files. But it's important before using the 15 hand file or the rotary path files to have a 10 working to be super loose in the root canal. So if we decide to do a manual glide path after using the 10K file, when the 10K file is super loose in the root canal, we are going to use the 15K file. So we start with the watch winding movements with the 15K file, and when this file reaches the apical terminus, we are going to change the movement, and we are going to start with the push-pull movement. When the 15K file is super loose in the root canal, we can consider that we have finished the manual glide path. If we decide to do the glide path using rotary files, for example, the M3 safe path files, the path files that now we are using, after using the 10K file, we have to analyze the root canal. If we have a root canal with a severe curvature or a root canal that is narrow, we are going to use the 13, that is the purple, and the 16, the white one, to do the glide path. But if we have a not very difficult case, that it's not a case with a severe curvature, or it's a canal that is wide, we can use directly the 16 path file. What is the advantage of using rotary glide path instead of using manual glide path? First, the time that we have to spend to perform the glide path is much lower if we use rotary glide path. But we have more advantages. The extrusion of debris provoked during the instrumentation it's lower if we use rotary path files. And we have another advantage. The apical transportation provoked by rotary glide path is lower than that provoked by a manual glide path. And lastly, is that the rotary glide path is easier to do, to carry out than a manual glide path. There are many cases that to do the glide path with the rotary files is not compulsory, but there is a root canal that I think that it's much easier to do using a rotary path file. Is the MB2. Probably the MB2 is one of the most challenging root canals that we do every day in our clinical practice. So now I'm going to explain the procedure, the steps that I do in order to treat this canal in the part of getting patency. First, I use a 10K file up to 2/3 of the root canal in order to know that the root canal is open. Okay. After that, I enlarge a little bit the coronal part of the root canal and eliminate the interferences that we have at the entrance of the orifice. To do this, you can, as we will see later, you can use the 2506 of the CC file premium system, or you can use the 1712 of the same system. You can choose both. It depends on you. After that, after enlarging the coronal third and eliminating the coronal interferences, I use the 8K file. Then I start with the winding movements up to the working length, up to the terminus of the root canal. When the file is at the terminus of the root canal, we start with the post-pulse movements. Then, when the 8 is super loose in the root canal, then I change and I start to negotiate the root canal using the 10K file, using watch winding movements. When the 10K file reaches the apical terminus, then I start with the push-pull movements. And when the 10K file is super loose in the root canal, then at that moment, I start with the path files. Then the first path files that I'm using now is the 13 of the M3 safe path files. So we introduce this file inside of the root canal with a low torque. I am using a 1.6 torque with 300 RPM. So in the moment that you feel that the file cannot penetrate, cannot go deeper and deeper, it means probably that there is detritus in the flux. So when you realize that the file is not advancing inside of the root canal, remove the file, clean the flux, and put the file again in the root canal. And repeat this procedure up to the point that the file can reach the apical third. But it's very, very important, if you feel that the file cannot reach the apical third, don't press. Remove the file and clean the file, and then insert again inside of the root canal. So, when the 13 path files can reach the apical third, so we are going to use the 16, and we do the same procedure. We introduce, so we can see that the file go deeper and deeper. And at the moment that the file cannot go deeper, so remove the file, clean the flux, and introduce again inside of the root canal. if the flutes are with a lot of debris, the cutting efficiency of the file is going to decrease. If the cutting efficiency of the file decreases, so the file will need more pressing in order to penetrate inside of the root canal. And then the torsional stress will be higher. So for this reason, it's very important when we realize that the file is not penetrating deeper and deeper to clean. Another important thing that we have to analyze when we use a file is the cross section. Why? Because if we have an efficient file, if we have a file that cuts efficiently, the torsional stress will be lower. So the chances of having a fracture due to a torsional stress will be lower than if we use a file that is not efficient. So the cross section of the CC files are an italic S. And this cross section, according to Max Spaden in the book, is slightly positive. So what does it mean? It means that this cross section, this kind of design, is very effective to cut the dentin and to remove the debris that we create during the instrumentation. For example, here we can see a case. The root canal is straight. There is no curvature. But we have to know that we can have a fracture due to a torsion in a straight canal. Why? Because the torsional stress is due to the contact between the file and the walls of the root canal. So if we have a root canal that is narrow, we will have a lot of contact between the file and the walls of the root canal. So we'll have a high torsional stress. So, for example, they sent me this case, not because of the curvature, it's obvious that it's a straight canal. They sent to me this case because if you pay attention in the X-ray, you can see that the root canal disappears in the middle of the root. After doing a CBCT, we can see a wide root canal in the coronal part, but after that, the canal disappears for 2 millimeters and is narrow in the apical, in the middle and the apical part. What does it mean? It means that the file will be under high torsional stress when we shape this part of the root canal. So, for this reason, it's very useful to use files with the design of CC files. Why? Because are very efficient when we are using these files inside of the root canal because they cut very well. An easy way to decrease the number of fractures due to a torsional fracture is using a handpiece with control torque. Now we are using the WISMI. Why the WISMI? With the WISMI, I don't know if you know this motor, has 10 programs, and you can decide the RPM, you can decide the torque. If you want to use only apex locator plus motor, only motor. So we can, and it's very light, this motor. So we can say that I feel very comfortable and I think that it's very easy to use. For example, why these kind of motors are very useful when we do endo? They send me this molar. You can see that they did the access opening, but they sent the case because they didn't find the MD1. So they found the distal vocal and the palatal, but for them it was impossible to find the ND1. So, when we have to keep in mind that the path files are very useful to do, the rotary path files are very useful to do the glide path, but the diameter in the tip of the file is small, and as we know, the resistance to torsional fracture is related to the mass. If we have a big size, we will have a high resistance. But in cases of glide path files, the diameter of the file is small, so we cannot press a lot. The problem is our tendency, our temptation, when the file is not going deeper and deeper, is to press. But if we use this kind of motors, these motors can control our instinct, our temptation to press. And in this way, this motor avoid a lot of fracture. So, for example, the MB2 is a very difficult root canal, as we explained earlier. So, if you use this kind of motor, for example, the Wismi motor, and you press a lot, so the file is going to stop in the root canal. You cannot continue with instrumentation, and in this way, you are going to avoid the fracture. Here, we can see the case after using the glide path and after using the CC file system. If you analyze the preparation of all the cases, you will see that it's very, very conservative preparation, so we are not going to weaken the root. Now we are going to start to talking about the cyclic fatigue fracture. We have talked about the torsional fracture. Now we have to focus in the other kind of fracture that we can do with our rotary files. Is the cyclic fatigue fracture. So, cyclic fatigue fracture is due to the compression and tension that occurs during rotation of a file around a curvature. These repetitive compression and tension cycles could provoke a cyclic fatigue fracture. Not always, but sometimes. So we have to know that always that a file is in a curvature, it's going to be under cyclic fatigue stress. So, in order to decrease the failures, the fractures of the files due to a cyclic fatigue, we have to analyze, we have to know, as these four factors, the diameter, the degree of curvature, the position of the curvature, and the Nike alloy can influence on the cyclic fatigue resistance of the file. On the contrary of the torsional stress, cyclic fatigue, the smaller files have better resistance to cyclic fatigue. So, if we have a severe curvature, we are going to use, in order to decrease the cyclic fatigue stress, and small files, or files with small tapers. We can use files with O4 taper or O2 taper instead of using files with O6 or O8 taper. The position of the curvature is very important when we analyze a case. Why? Because, as we explained earlier, the higher the mass, the higher the diameter of the file, higher the chances of having a fracture. If we have a curvature like this, that is very coronal, between the middle and the coronal third, we know that the file is going to be under a high cyclic fatigue stress. Why? Because imagine that we want to shape the root canal with a 2506 file. It's a file that we have in the CC premium system. If the curvature starts 2 millimeters shorter from the working length, the diameter will be 37. But if instead of starting 2 millimeters shorter from the major foramen, the curvature starts 4 millimeters shorter, the diameter of the file will be 49. So the diameter is much higher at the point of 4 millimeters shorter than 2 millimeters shorter. Why? Because if the curvature starts 2 millimeters shorter, the mass of the instrument, the diameter is 37. But if the curvature starts 4 millimeters shorter from the working length, the size is 49. And if the curvature starts 6 millimeters shorter from the working length, the diameter will be 61, so much higher. So the risk will be higher if the coronal curvature starts in the coronal part of the root canal. Another easy procedure that we can do in order to decrease the stress of the file is to eliminate the coronal interference that we can see with the arrow. Why? Because if we get a straight line access to the middle or apical root canal, the cyclic fatigue stress will be lower. Why? Because if we don't eliminate this coronal interference in the entry of the orifice, the file is going to bend in that point. So if the file is bent in that point, it's going to suffer cyclic fatigue. So it's very important in those cases with a coronal interferences, for example, the molars, the root canals of the molars, to eliminate at the beginning of the preparation this coronal interference. Here we can see a CBCT of a case with the arrow is the entry, and then we can see that we don't have a straight line access to the middle third. So if we don't eliminate this interference, we will have two curvatures. The curvature in the entry of the root canal and the curvature in the middle or apical part of the root canal. So we will have to face with two curvatures, so the file will be under high stress. So how can we eliminate these coronal interferences? So we can use the file designed for this end in the CC Premium system, that is the 1712, okay? Doing brushing motion movement. It's with the brushing motion against the outer part of the root canal, we can eliminate this coronal interference. Another way to do it is instead of using the 1712, we can use the 2506. But the most important part, independently if you use the 2506 or the 1712, is use a brushing motion against the outer part of the root canal. So, after eliminating this coronal interference, we can see, you can see in your right with the arrow that the curvature, the first curvature, is located around 3-4 millimeters from the terminus of the root canal. If we don't eliminate this coronal interference, probably the first curvature will be in the entry of the root canal. For this reason, it's very, very important to eliminate this coronal interference. So, how did we do this, shaping, the shaping of this root canal treatment? First, always use the 10K file and to explore if the negotiation of the 2/4 of the root canal. After that, we can eliminate this coronal interference and enlarge the coronal third of the root canal with the 2506 or the 1712. After that, we do watch winding movements up to the working length. Then we start with the post-pole movements, and when the file is super loose inside of the root canal, then we start with the path files, with the S3 safe path files, the 13 and the 16. After that, we use the 2004 of the CC premium system to the working length. And after that, we use the 2506. It's not compulsory that this file to reach the coronal, the apical part. So we recommend to use in the following way. We introduce the 2506. And when we realize that the file cannot penetrate deeper and deeper, we remove the file and we clean the file. And we repeat these movements or this sequence and we stop when the 2506 reach the apical third. But if we realize that the 2506 cannot reach the working length, we remove the file and we cannot see debris in the fluid. It means that this file is too big to reach the working length. So if we see that this file cannot reach the apical third and it's free of debris, so stop your instrumentation. This is the case after finishing the preparation and after filling the root canals. Another important thing that we have to keep in mind, it's not only the position of the curvature, another important thing to analyze if the curvature is severe or not severe, and if abrupt or not abrupt. If we have an abrupt, so it changes quickly the direction of the root canal, the cyclic fatigue stress is higher than if we have a progressive curvature. If we compare to curvatures, we can see that the curvature in the left, it's progressive curvature, and the curvature in the right, it's abrupt because it changed quickly the direction. This is the case, the initial X-ray and the two final X-rays. We can see the curvatures, we can see that the MB2 field. So, what to do in these cases? So, in these cases, I think that it's better to finish with the 2004 instead trying to use the 2506 to the working length. Why? Because the difference of size between the 25 and 20 in the tip of the file, it's not very big. It's 20 versus 25. But as the 2506 has a taper 06, if the curvature is located 7 millimeters shorter from the major foramen, for example, like this case, we can see that the diameter of the file in that point is 67. On the other hand, if we use the 2004, the diameter of the file 7 millimeters shorter from the working length is 48. So the difference is too big. So the cyclic fatigue stress using the 2506 up to the working length, it's much higher than if we use the 2004 up to the working length. So for this reason, in these cases, we use only the 2004 up to the working length. So now we are going to explain the sequence that we use in these cases. At the beginning, it's the same tooth first with the 10K file. After that, the 2506 to remove the coronal interferences and increase the diameter of the coronal part. After that, the 10K file to the working length, the glide path with the 14 and 16. And then we change a little bit the sequence that we explained in the anterior case. We use the 2004, but we don't use the 2004 up to the working length. No, we use the 2004 3/4 of the root canal. After that, we use the 10K file up to the working length to eliminate the tritus and to be sure that we have patency. After that, we use the 2506 up to 3/4 of the root canal, and finally, we use the 2004 to the working length. So the question, it could be, why do you use the 2506 3/4 and you don't use the 2004 directly to the working length? I use the 2506 3/4 of the root canal in order to increase the diameter in the middle and coronal part, and then the 2004, it's only going to work in the apical part. So we are going to decrease the stress of the 2004. If you are not happy because you think that 2004 is not big enough to shape the root canal, and we know that perhaps for this case 2006 it's too big, you can use 2504 or 3004 to the working length. UDG Bondent has a lot of systems, and then you can find 2504, for example, in Platinum 2018, you can find the 2504. And another important thing that we have to analyze is the alloy that the file is made. Why? Because there are a lot of kinds of 90, and some of them are more flexible and are more resistant to cyclic fatigue. So, summarizing, we can find a 90 files made of martensite 90. It means that at body temperature, this file is in a martensite phase, and we can use files made of austenite 90. What does it mean? It means that at body temperature, the file is in austenite phase. And why is this important? It's important because the resistance of the file that is working in martensite phase at body temperature, it's much higher than those files that are made in austenite at body temperature. So the CC file system, the files are made in martensite 90. It means that at body temperature are in martensite phase. And why is it important? Here we can see a case that I did 10 years ago with an austenite phase 90. So we could do this kind of cases with austenite phase, but what was the problem? The problem is that the risk of fracture is higher than if we do this modern 90 files as CC files. So if I had to do this case today, I would choose a file made of martensite 90 as the CC files system. This, the files made of this 90 has another advantage, is that in theory, these files has to transport, the apical transportation should be lower. Why? Because this at body temperature, this file doesn't have memory save. What does it mean? That this file doesn't have the tendency to recover its original shape. And if a file doesn't have this tendency to recover its original shape, the lateral forces of the file against the wall will be lower. And if these forces are lower, the tendency to transport the root canal, in theory, should be lower. So, potentially, these files, we are going to provoke less apical transportation. So, for this reason, these files made of martensite 90th body temperature with memory control are very useful in cases with a severe curvature. For example, this case was carried out with CC file, and the sequence used was the next one. 2/3 of the root canal with the 10K file after the 2506 to remove the coronal interferences and to enlarge the coronal third. After that, we use the 10K file up to the working length, and we use the glide path files. After that, instead of using the 20, in very difficult cases with a very severe curvature like this, instead of using the 2004 directly to the working length, we use 3/4, okay? We use the 2004 in the first 3/4 of the root canal, and after that, the 2506 to the same position. And after that, and when the 2506 can reach the 3/4 of the root canal, we use the 2004 to the working length. And this is all I wanted to explain to you. I hope you to find this lecture useful.
Thank you, Dr. Fernando. This was a very well-explained session, and thanks for sharing your knowledge and experience with us. I'm sure all participants would have learned how to simplify complex cases and dental practice. Starting with a question and answer session. The first question is from Dr. Mahmood Hassan. How to prevent ledge formation and perforation?
Ledge formation, okay, a very interesting question. Okay, I think that a very useful way to avoid the ledge formation is to use the glide path files, okay? Because if you have a glide path, so it's much easier to avoid ledges. Another way to avoid ledge is don't press a lot when you are using the shaping files. And the ledges that you can do during the negotiation, you have two alternatives. Now we are going to spend a little bit of time to explain this. If you feel that the 10K file cannot reach the working length, it could be for two reasons. The first one is the canal is too narrow. So if the 10K file cannot reach the working length, so if it's due to because the canal is too narrow, so you take an 6K file and introduce the file inside of the root canal. If the 6K file can reach the apical part, so you start with the push-pull motions, and after the 6, the 8, and after the 10. But if the 10K file cannot reach the working length, and you use the 6K file, and this 6K file cannot reach the working length, it means that there is a severe curvature in the apical third. So, in order to bypass this curvature, you should prevent an 8 or 10K file.
Thank you, Doctor. The next question is from Dr. Rimple Gupta. please explain pre-curving of file in maxillary molars.
Excuse me, can you repeat the question?
Please explain pre-curving of file in maxillary molars.
Okay. You can pre-curve in theory, you pre-curve when you want to bypass a curvature, you want to bypass a fracture instrument, you want to bypass a ledge, you have to use a pre-curve file. So you have to bend the last 2 millimeters of the file in order to try to bypass these problems that you can find. Another thing, because it's if you want to pre-curve the file, the rotary files, when you have a patient that this patient cannot open a lot the mouth. So if you use a Martenside 90, for example, the CC premiums, you can prevent in the coronal part of the file, so it's much easier to introduce the file inside of the root canal.
So the next question is from Dr. Tanu Agarwal. Why does pain occur even after proper cleaning and shaping of the canal?
Independently of the system that we are going to use, always we are going to provoke an extrusion of the debris out of the tooth, always. But depending of the bacteria that are inside of the root canal and depending of the amount of debris that we are going to extrude, we can provoke or not. But we have to keep in mind that between 2 and 5% of the cases with periapical lesion will have a flare-up, will have pain, a severe pain after, independently if we do correctly or not. Why? Because we are going to extrude the tritus always.
We can see you, doctor.
Okay.
So the next question is from Dr. Rosemary. Which is the best file system for curved canals?
Okay, I think that you have to pay attention to the properties of the files. I think that if you are facing with a very severe curvature, you need path files. Okay, it's compulsory in order to start with the instrumentation, because if you want to do a severe curvature using hand files, the chances of doing a ledge is high. So path files, compulsory. After when you are using, then you have the path files and you have to decide what system is the best for the shaping files. I think that you have to focus on the 90 alloy. You have to choose a 90 alloy that work in Martenside phase at body temperature. So all these characteristics you can find using the M3 safe path files and using the CC files premium system. But if you have a severe curvature, please don't use the 2506 up to the working length. Use only the 2004 to the working length.
Thank you, doctor. Coming to the last question, I think you have already explained in your presentation, but still Dr. Rose wants to know, how can we shape curved canals?
Well, I think that, as you said, that explained sometimes. I think that the best, if the curvature is not severe, it's a normal curvature that you can use. First, you have to shape the coronal first with the 10K file. After that, remove the coronal interference using the 2506 or the 1712. After that, the negotiation with the 10K file. When the 10K file is at the working length, to do the push and pull motions. And when you feel that the file is super loose, you should use the 13 and 16 path files. So this part is common in severe curvatures and in non-severe curvatures. But if you have a non-severe curvature, so you go directly with the 2004 to the working length, and then you try to reach the working length with the 2506 after using the 2004. But in cases that you have a severe curvature, I think that it's better first to shape the root canal up to 3/4 with 2004. After that, 2506 to 3/4 of the root canal. And after that, 2004 to the working length and stop your instrumentation.
Thank you, Dr. Fernando, for answering all the queries from the participants. I thank all the participants on behalf of Bondent Group for your valuable time. You can see the recording of this webinar on our YouTube channel. Our downloadable certificate option is available on the login page. Please click on it to get your e-certificate. We are happy to share with you that we'll be showcasing our products in Egypt, Dubai, hall number 8G06 from 29 July to 29 June to 1st July. Expert speakers, business leaders are going to be present on the booth to share their expertise and knowledge with you. We also have a comprehensive clinical education schedule listed on the social media handles. Please register yourself to grab a seat as the seats are follow our social media pages on Facebook and Instagram to make it easier for you to get information about our upcoming webinars and product launches. Thanks everyone once again. Have a good day. Thank you, Dr. Fernando. Thank you so much for your time.
Goodbye. Enjoy your weekend.
Thank you, Doctor.